Well, so from my side, thank you for you being here. After 2-3 nights of partying, I think it's real great that you are here. As Jean said, I'm from ACTA, the Academic Center for Dentistry in Amsterdam. And as you can tell from the people that drew this map, Amsterdam is in the center of the world. At least that's what we consider. But I've noticed traveling that maps change depending on the country you're in. The topic of this morning is interdental cleaning, and what I hope to provide you with, and I'm sure I will, is that in the end I'll give you the evidence of where we are right now. But before doing so, I'd like to set the stage. It has been a busy day. You've been working on a patient who has been very difficult, and you're glad to get your cup of coffee. And then the front door bell rings on one of these days, and somebody, a sales representative, puts his foot between the door, shakes your hand and says, "Doctor, I have something special to introduce to you. I have a new, and the new product is called Ardox X. And Ardox X is a patented technology, and then he explains to you all the features that it has. He tells you about the products that are available, and I'm sorry that these products are in Dutch, but he caught my attention the moment that he said, "We have a shampoo that makes your hair grow." And then he had some oral hygiene products, and they also had products which help to keep and maintain implants healthy and clean. Actually, it was a product that has many features, looking at what the array of properties are. It helps against whitening, tongue burning, oral malodor, sensitive teeth. Looking at all these properties, you wonder what is the evidence with respect to Ardox X. So in evidence-based practice, we as dental professionals go through a procedure of various steps. And the first procedure is to ask a clinical question. So you have the product, and the question you ask yourself is, what would it do in my practice? And for this we use a PICO. A PICO is the patient, the intervention, the comparison, and the outcome. So if we translate Ardox X to this question, it would be, in my patients, if I use Ardox X compared to not using anything else, what would be the outcome with respect to plaque and parameters of gingivitis? Well, the next step would be to go and search for the evidence. And for this we can go to PubMed. It's easy, accessible, and we enter the search term Ardox. And if we then press on the search button, what comes up is one study. It's actually a study from our own group in Amsterdam, and it only relates to implants. So we further revised the search question, and then we put in Ardox and dental, looking at teeth. And then when you see that there is actually no study supporting all the evidence, all the claims that the sales representative has made. So in this process of these 5 steps, we actually have a hiccup somewhere between the searching for evidence and the judging for, because there's no evidence to judge. Well, it's easy to continue this progress if we look at chlorhexidine. If you would enter chlorhexidine in dental, it would be a total different question. Looking at the number of papers that you retrieve, somewhere close to 3,000 papers, and if you still think that is not enough, you can go to other databases such as the Cochrane or the Embase and retrieve additional papers in order to provide you with the evidence with respect to the chlorhexidine. After you've judged the evidence, the next step would be to try out what you have learned, then you evaluate, And this is actually a continuous process. We call it now lifelong learning, where you as a dental professional try to improve what you tell your patients and what you do with your patients throughout your life. And I think this is, from the last years that we're looking at this in such a way, and I think it's a challenging and also an intriguing way of looking at the data that are out there. For instance, we have performed a systematic review on manual brushes quite recently. It will be published in the August issue of the International Journal of Dental Hygiene, and we did a sub-analysis looking at various toothbrush designs. So we looked at flat-trimmed, multi-level and angled toothbrushes, and if you look at the efficacy that these brushes provide, if you look at the science that is supporting it, it's somewhere between 24 and 47% flat-trimmed toothbrush, and it's for an angled, the latest development in toothbrush design, somewhere between 39 and 61. So what we learned from this is that toothbrush design has an effect on the efficacy that we obtain from manual toothbrushes, but we also learned that even with the most effective toothbrush design, we're still far away from the 100% that we might want to get. Well, if our patients brush, and you asked your patients to brush and you disclosed them, what you notice that at the interdental aspect, there usually still a lot of plaque. And the interdental aspect is the aspect where you get the dental diseases which are most common, which is caries and periodontal disease. Well, already 750 years ago, the great prophet Mohammed said, "You shall clean your mouth, for this is a means of praising God." And then he added something to it and said, "A prayer which is preceded by the use of a toothpick is worth 75 ordinary prayers." So he was probably the first one to propose interdental oral hygiene. Well, the Americans have a different way of preaching the gospel. The Americans say, "You floss or you die." And this comes from a publication by Raul Garcia, who explained the link between oral health and cardiac disease. And if you would be a patient and go to an American dental office, the dentist would you to floss. And if you don't floss, he tells you to floss. And if you still don't floss, you have to floss. And they go to extremes to make it tempting to floss. And they tell you you have to floss every day in order to keep your teeth healthy. And even in Hollywood, they have introduced flossing in their movies. A famous scene is from the movie Pretty Woman. And I'd like to join you to watch this little fragment.
This is dental floss.
Yeah, so I had all those strawberry seeds. And you should neglect your gum.
I'm sorry. Please continue.
Thank you. You're watching.
I'm going.
I'd like to mention two things about this lament. If you've listened carefully, you'll see that she explained that she's flossing because she wants to remove the strawberry seeds, not the dental plaque. But she is worried about her gums, so we as periodontists have really read something. The other thing is that it has been told that after this movie, the sales of floss increased by almost 30%. So probably the Americans try to pull in Julia Roberts into their bathroom with a piece of floss. But what is the evidence to support the use of floss? Well, if we go to PubMed and then look at dental floss, what we see is that we're close to 2,000 papers that come out. And these papers, and you've seen this already a number of times during this meeting, contain many studies. And if we as dental professionals need to go through all these papers, by the end you're finished, you'll be very tired and maybe not finish them all yet. And you might still be confused about the outcome of your search and going through all the papers. So to make it more simple, we as academics do the work for you, and we devise what we call systematic reviews, and this is also a term that has been brought forward many times during this conference. So let's look what is available with respect to systematic reviews and interdental oral hygiene. Well, the first paper I'd like to introduce to you is one by Philippe Houyoul, who looked at the relationship between flossing and interproximal caries. The focused question of this research was, what is the effect of flossing versus no flossing with respect to the incidence of interproximal dental floss? Well, he searched various databases, and in order to get an answer for your question, he uses search terms in order to get the papers that he is interested in. So what he was looking at was the intervention, which is flossing, the outcome, which would be dental caries, but on top of this he put a filter in his search strategy. A filter looked at randomized controlled clinical trials only. Well, for you to make this a little bit more understandable, I've made this little example of what is happening here, building a search strategy like this. Let's say we have a database that contains 3 papers that address floss, and there's 3 additional papers that look at caries, and there's 3 additional papers that look at both floss and caries, of which 2 are randomized controlled clinical trials. Well, based on the search strategy, you get different numbers of papers out of your database. For instance, if you would search for floss, these would be the papers that you get out from the database. If you would search for floss or caries, you would get them all. If you would say, I'm looking for studies that both look at flossing and caries, you only end up with these 3. And if you then add the filter only looking at RCTs, you only have the last 2, the flossing and the caries. Okay, so this was what's happening with the search strategy. If you go to a database, what you're actually doing is you're opening a virtual file cabinet, and in this file cabinet are folders which contain the information for you to answer the search question. So we pull up a folder after performing this search, and in this folder are 143 papers. And you go through titles and abstracts in order to select papers that provide you with an answer to your focused question. So they excluded 94 papers which did not this, which gave them 49 to read full text, and they picked up 1 additional one from the reference lists of these included studies. Well, after going through all of these, 44 were excluded, which left them 6 RCTs to provide the answer to their focused question. Well, presenting it like this, I've had many questions afterwards with people saying, what happened to all the other papers, the 138 papers which were not included? Is this information all gone? Well, please understand, we started with 143 and added 1 from the reference list. We ended up with 6, dependent on the question that we asked. The question gives you eligibility criteria, in this case looking at caries incidence and flossing. And those papers which not address this were not included. And also we excluded, or they excluded, papers that were review papers, papers that were case reports, non-English papers, papers that contained no data, only looked at microbiology and not at clinical data, or maybe only looked at acid production. So a systematic review really makes you focus on those papers that address the research question. So these 6 papers were split up into 3 subsections. The 3 subsections were papers that were looking at the effect of floss, where school children were flossed every day, 5 days a week, by a dental hygienist. Studies that looked at flossing by a dental hygienist every 3 months, and studies that looked at self-performed flossing, so what people do themselves at home. Well, they performed a meta-analysis based on this, and what you see here is a forest plot, and these are the data from the individual studies, which are then summarized in these little diamonds. And the overall result from this study is represented in this little diamond, and if you notice that little diamonds is the vertical axis, which tells you that there's no significant difference if you either floss or do not floss. So the only statistical difference that we find is when patients are being flossed by a dental hygienist 5 days a week. Then you see an effect of flossing on interdental caries. So their conclusion was that professional flossing in children, and this might be a takeaway message for you to tell the parents of your children that you're treating, is highly effective in reducing interproximal caries. But you cannot extrapolate these findings to more typical floss users because self-flossing showed no effect on caries. Well, how should you floss? What is the most effective and most professional way of flossing? So I went to the internet and looked at a video, a YouTube video, which told and explained how you should floss, and it's actually a video from Colgate. And just have a short look at this one.
Flossing is easy once you know how. All you need is about 18 inches of dental floss. Wrap it around your index fingers and leave 2 to 4 inches between your hands. Hold the floss tautly between your thumbs and index fingers and gently slide it between teeth. Slowly move the floss up and down, gliding along the side of each tooth. Curve the floss around the base of each tooth, making sure you dip beneath the gum line. Be careful. Never force the floss or move it roughly. As you move from tooth to tooth, use clean sections of floss. Continue flossing until you've cleaned between all of your teeth.
This is how you should do it, and if you do it like this, you probably get a very good effect. But there's another movie on YouTube, a 1-minute flossing instruction, and this is what I consider self-performed flossing. Just have a look.
Flush your teeth in 1 minute, so you can do it every single day. 1 minute a day, how to flush your teeth in 1 minute. Ready? Go. You pull it out to this, but you see how long that was, and you cut it off. And you take it, wrap it around here, wrap it around here. You keep wrapping until they're level. Watch, okay? Then you go up here. And you go to the other side, you keep opening it up. You see what I'm saying? Alright, then you come down here, see? You keep opening it, and you pull out, and it's fresh. You go up and down. Up, up and down. 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 Each one. Okay. Up and down, and you keep pulling. Okay, you keep pulling, so you always have fresh right there, see? Down. Up and down, so you're done with the bottom. Flush your teeth every day. You don't have a minute for oral hygiene, that's a minute that you're going to regret. Everybody floss. You can do it in a minute a day.
Okay, that's the difference, probably. Yeah. Okay, we just discussed the effect of flossing on caries. We as a group at ACTA looked at various interdental products with respect to the level of gingival inflammation. So this systematic review from Claire Berger, looking at flossing and plaque and bitus reduction, had the following search terms. As you can tell, it's a little bit different from the previous one I showed. What we as a group try to do is try to be as comprehensive as possible. So we enter as many search terms into the search strategy in order to not to miss any papers. And we personally do not like to put on these filters as well, because these filters have been indexed by somebody else, which might not be the same index that you would use as a researcher. So it's also more work. Instead of 143 papers, you all of a sudden end up with 1189, which you then have to go through titles and abstracts in order to select the studies that are eligible for this research. So from 1189 we go to 36 with an additional one from the reference list, and then 26 are excluded after full text reading, which leaves us 11 papers which are suitable to provide us with an answer to the question. Well, first of all, I'd like to show you a descriptive way of looking at the outcomes of these studies. Here you see the 11 studies, and they looked at these parameters, looking at plaque, gingival index, and bleeding scores. And we summarized these studies by giving them a 0 or a plus. 0 would mean that there's no difference between flossing and not flossing, and a plus would indicate that actually flossing is more effective than not flossing. Well, let's fill in this table and make it a little bit more easy. These studies did not address the parameters that are at the top. These studies showed that there's no difference between flossing and not flossing. And these studies tell you that flossing is more effective than not flossing. And there's one that has data which we could not understand. Well, if you then summarize this into what is called vote counting, you can say, well, there's 3 out of 10 that show that flossing has an effect on plaque. 0 out of 8 shows that with respect to the gingival index there is a change, and only 1 out of 4 tells you that there is effect on bleeding. Well, the data that we had allowed us to perform a meta-analysis, which is even one step above a descriptive analysis. And as we've seen before, a meta-analysis is illustrated in a forest plot. These are the individual data, and this is the overall outcome of the meta-analysis. And again, the little diamond is crossing the vertical axis, which shows you that there's no significant difference as you compare flossing versus no flossing. So the conclusion of this paper was that routine flossing in gingivitis patients as an adjunct to toothbrushing is not supported by scientific evidence. We have changed the conclusion a little bit by adding to it that dental professionals should determine on an individual patient basis whether high quality flossing is an achievable goal. Because we have seen in the Philippe Rouliol study that if you have a dental hygienist doing the job, then you do see an effect. Recently, the Cochrane group published a similar review. What they did is they broadened their eligibility criteria a little bit. They did different statistics, and you might agree or might not agree with it, but this Cochrane review was not more promising than what we found. They said there's some evidence that flossing has an effect on gingivitis. There is weak and very unreliable evidence that it has an effect on plaque, and there's no evidence that it has an effect on caries. Well, let's add a little bit to the confusion, or maybe make it, I try to explain a little bit more whether we should clean interdentally or not. This is a picture of the marginal gingiva as we most often see it. If we look at the anatomy, it's oral epithelium, oral sulcular epithelium, and junctional epithelium. And the junctional epithelium is actually attached to the tooth surface and prevents the oral microorganisms from entering the body, and which is a remnant from the embryonic state. It's called the reduced enamel epithelium. And since we most often look at it is presented on the left-hand side, you might not really grasp what the junctional epithelium is doing. But if you illustrate it in this way, it's actually like a piece of Scotch tape which runs around the tooth and glues the marginal gingiva to the tooth. And if you look interdentally, the papilla goes all the way to the contact point. Underneath the contact point is junctional epithelium. If you run from buccal to lingual, there's junctional epithelium which prevents bacteria from entering. So you may even ask yourself the question, if the gingiva is healthy, should I disrupt this and make it accessible for bacteria? Why don't I stay away from the interdental aspect? Well, in one of his textbooks, Per Axelsen had the following illustration. Explained that if you look at the interdental aspect, if you look at central incisors, and that the distance between the buccal and lingual is so small that you might not even be necessary to clean interdentally if you would do a proper job on the buccal and lingual aspect. Maybe if you look at the molars, the distance is a little bit wider, it might be necessary, but with the incisors, who knows, it might be sufficient to clean only with a toothbrush. And as those that you know me from the work that we've done also know that we've done a lot of work on power toothbrushes. And these power toothbrushes have been shown that they remove plaque from the approximal aspect to a very high extent. To illustrate this, a little video. The video, this is how the brush really adapts to the tooth surface, and these are transparent teeth, and you see that these filaments, the toothbrush filaments, really enter the approximal aspect between the teeth. So if the distance between buccal and lingual is not that big, this might be sufficient, and we should not disrupt the intact junctional epithelium. Now we should have a next slide, so let's see what's happening. Okay. Well, realizing that it's almost 200 years ago that floss was invented, it's actually crazy to understand that I'm standing here telling you that it's not working. And yeah, what do we consider at present? I think the conclusion is that self-performed flossing does not significantly remove plaque in general with our patients, and does not significantly inhibit caries and gingivitis. So what is left for the floss? What can you use it for? Well, there's many pictures on the internet which show you the alternative uses. You can cut some cheese with it, you can make these nice salads, and even if you were a plumber, it might be a very useful tool. And all of us know that if you want to hang a painting on the wall, floss is also very effective. But is this fair to do it like this? Well, some companies have taken this message and have already translated it into their commercials. And again, a little video which is a compilation of a number of commercials.
fact that dentists and dental hygienists have been encouraging us to floss for years, many people don't floss enough, and some don't floss at all. Flossing with string can be time-consuming and difficult.
So it has been picked up by various companies. But as I said, is it fair? And what do I tell my patients when you return on Monday? Well, do I tell them to throw away the floss? Well, for this we have to make, as dental professionals, an evidence-based decision. And this figure has been shown already a number of times. We have looked at the scientific evidence. We've seen that there is very little to support the use of floss. We can consider patient wishes. It might be that people like to use floss, or maybe they don't. And I think I have one more video, which is here, because there's many excuses on the internet not to floss. Again, a compilation of what I found.
Causes my gums to bleed.
It hurts.
It gets stuck.
Shreds. I can't remember.
I don't have the time.
Time is probably number one. And you throw it away and it doesn't really let go of your hand. I can't get my fingers in there.
My hands are too big.
I can put my foot in my mouth better than my hands.
The floss gets caught around my fingers.
I don't know how.
I don't feel like it. I didn't get to it.
My dog ate my floss.
That's a really lame excuse. It breaks.
I gag. I forget. I ran out.
I'm too tired. It's not fun.
I was on vacation.
So many excuses not to use it. But if it's the only available tool that you have, it might still be worthwhile. For instance, we all consider power toothbrushes to be more effective than manual toothbrushes, but would be dentists working in the middle of Africa. You can tell your patients to go and get a power toothbrush, but they probably cannot afford it, and probably will be very difficult to buy one. So it's also the available tools that we have, whether we consider the use of a specific oral hygiene product. And then there's the clinical experience. An example to show and explain what the clinical experience would be. If you have an implant dentist and a prosthodontist having put a lot of energy in trying to get this nice gingiva around this crown, and then as a hygienist you tell your patients, well, why don't you use a wood stick or an interdental brush? You depress the nicely formed interdental papilla, so it might be worthwhile in these patients to use floss. That could be the most effective tool in this type of patients. So to say that flossing is not worthwhile to use is not fair, and you have to consider it based on your clinical experience as well. And to illustrate it a little bit more, this is a slide that I've obtained from Procter & Gamble, where they asked patients not to brush for 7 days. And then they take these special pictures, and they illustrate it by going from green to red. Green tells you that there's an improvement in the level of gingival health, and red tells you that there's a worsening. And please understand that in this case, patients did not brush for 7 days, but only flossed. And then you see that floss still has an effect on the interdental papilla, turning green, so it means that there's an improvement. Well, this is 7 days of not brushing. My colleague Dick Barendrecht also performed a study where patients did not brush for 21 days and flossed. In this particular study, we looked at various bleeding indices and wanted to include a treatment. So the subjects, the participants, were instructed to floss at a very high level, and then were asked not to brush their teeth and floss one half of their mouth and do not floss the other half of their mouth. So let's have a look at what's happening to the plaque. You see that in the treatment group, there's an increase from 0 to 0.676, where in the non-treatment group you see that the increase in plaque is much larger. And looking at gingival, this is the baseline. This is the increase in gingival inflammation. And the little stars tell you that there is a significant difference. So in absence of toothbrushing, flossing does seem to have and provide you with an effect. But in order to get this effect, you need to know how you should use your oral hygiene product, your dental floss. And as a group, we have made an attempt to make these instructions for various oral hygiene products, which are published in the book by Jan Linde. So as a dental professional, you can turn to this book and see how we think you should use the products that are out there. There's very nice pictures with respect to manual toothbrushes, but also to floss. And these also contain instruction with respect to the wood stick and the interdental brush. And the rest of my lecture I will focus on these two other interdental tools that we have. An advertisement from a long time ago explaining that dental floss is better than toothpicks. And again we ask ourselves, what is the evidence that we have to make a claim like this? Nienke Wunderdas, one of our group, looked at the efficacy of wood sticks in relation to plaque and gingival inflammation. So we first start with a focused question, and the question is that for patients using a toothbrush, can a handheld, and in this case triangular wood sticks, because there's many forms out there, but we particularly looked at the triangular wood stick, would be the effect with respect to plaque and gingival inflammation. We retrieved from our search 199 papers, out of which 8 were selected. Well, these are the publications that compared wood sticks to toothbrushing only. And these are the parameters that were evaluated. And by now you are able to read this table. These are the studies that show that there is no difference between wood sticks and flossing. And these studies tell you that there is a significant difference in favor of wood sticks. Tell you that there's no difference between wood sticks and toothbrushing, and these tell you that there's a difference between the use of a toothbrush and wood sticks in favor of toothbrushes only. There were also papers that looked at comparison between wood sticks and dental floss, which are summarized here, and one study even said that wood sticks were worse than use of floss. Well, summarizing these data, we were not able to perform a meta-analysis, but this study was restricted to a descriptive analysis only. The conclusion is that as an adjunct to brushing, wood sticks do not have an additional effect on visible plaque, but do provide an improvement by reducing gingival inflammation, as I showed you from these tables. With respect to interdental brushes, my colleague Dagmar looked at the evidence that was out there. Again, the focused question: what is the effect of the interdental brush as an adjunct to toothbrushing alone, or other oral hygiene products with respect to plaque and parameters of gingival inflammation? The search gave 234 papers, out of which 9 were selected, and these 9 are presented in a descriptive analysis here. You see that there are comparisons to brushing only, comparisons of the interdental brush to flossing and to wood sticks. These are the parameters, and now we have added one. We've also looked at the effect of pocket depth. This is the table, and these studies tell you that there's a significant difference in favor of the interdental brush. Well, let's do a vote count first. It shows you that 8 out of 11 papers tell you that it's more effective removal of plaque. 1 out of 5 on the gingival index, 0 out of 6 with respect to bleeding, but 2 out of 3 with respect to pocket depth. To illustrate the effect on pocket depth a little bit more, I've taken a study from one of my master students who introduced various oral hygiene products in patients that were not performing interdental oral hygiene themselves. So she asked patients to use, in this case, an interdental brush. People came in, and she examined the pocket depth at the baseline of the study, and this represents the percentage of pockets which are equal or larger than 4 millimeters. This is the baseline and the 6 weeks, and you see that by introducing an interdental brush, you get 10% reduction in the pockets that are deeper than 4 millimeters. So it shows you that the interdental brush has an effect on pocket depth, and looking at it clinically, it's easier to understand. You see that the brush actually depresses the gingival papilla, which provides you with a pocket depth reduction. Well, with this interdental oral hygiene tool, we were also able to perform various meta-analysis. All these were comparisons with floss. One meta-analysis looked at plaque as was assessed according to the Silness and low plaque index. Another one with plaque recorded by Quickly and Hine. One looked at bleeding and one looked at pocket depth. These are the weighted mean differences, and these are the 5% confidence intervals, and if 0 is not within this interval, it tells you that there's a significant difference, which was true for only looking at plaque. So the studies that were out there tell you that if you look at the plaque, which is interdentally, and you score it according to the Silness and low plaque index, you see a significant effect of the interdental brush. And this is what we now consider, this meta-analysis, the highest level of evidence that is out there. So the conclusion of Dagmar was, as an adjunct to brushing, interdental brushes remove more dental plaque than brushing and flossing. Well, to finish this lecture on interdental oral hygiene, it would be fair to add any tool that is out there, and also the water pick is a tool that is quite often advised by us as dental professionals for the use interdentally. And there is some evidence out there. Ali, one of our students, looked at this, and he came up with 813 papers out of 7, which 7 were selected. These are the papers. You see comparisons to the toothbrush only, and you see comparisons to regular oral hygiene. So in the top 3 comparisons, they tell you to use only a toothbrush. In the other ones, they allow people to perform their own method of oral hygiene. These are the 4 parameters that we evaluated. This is the table when we fill it in, and we see that the water pick does not have an effect on plaque, but seems to have an effect on bleeding, on gingival inflammation, and also on pocket depth. This is the vote count, where you can see that with respect to bleeding, 3 out of 5 show a significant effect in favor of the water pick, 3 out of 6 with respect to the gingival index, and 2 out of 3 with respect to pocket depth. The conclusion from Ali was, as an adjunct to brushing, the oral irrigator does not have a beneficial effect in reducing visible plaque, but there is a positive trend in favor of the oral irrigating improving gingival health. And I must tell you, for me this was a surprise, because I, as a student, was being told that you use the water pick to remove breadcrumbs from in between your teeth. It was not effective at all for interdental oral hygiene. But from this research, from this systematic review, you can tell that although it does not seem to have an effect on plaque scores, which we can assess only on the visible aspect of the tooth surface, please understand this, while we're performing interdental cleaning, it does seem to have an effect. And in a recent study by my colleague Martijn Rosema, where we also looked at the water pick and compared it to flossing, so toothbrushing and oral irrigator compared to flossing and using the toothbrush, we show that it is more effective in reducing gingival bleeding than the use of floss. So this confirms what the systematic review showed us. But the effect of the water pick is dependent on, let's say, the size of the interdental space. And this is the word that you need to realize whenever you tell your patient, or think that you need to tell your patient to use a water pick, which is shear force. Depending on the size of the interdental aspect, you either get an effect or don't get it. If it's small and then use the oral irrigator, then you get shear forces that remove the biofilm from the surface along which the water will flow. So if you have water that flows with a high velocity through a very tiny hole, then it does remove biofilm. But if you have a big hoop and then use your high pressure water on this, then you have a water spray growing through, but no shear forces on the sides. So what would be the indication of the water pick? That is restricted to patients that have small interdental spaces. So for me, the indication would be to use it as an alternative for floss, but in our perio patients, that is, doesn't work at all. You just blow water through a big hole with no shear forces at all. Well, the 4 publications that I presented to you this morning are combined in this issue from the International Journal of Dental Hygiene, and I'd like to summarize them in the next slide. So this morning we've looked at 4 interdental oral hygiene products. We looked at floss, wood sticks, the interdental brush and the oral irrigator. We looked at 4 parameters. We looked at gingival index, bleeding, and this is the outcome if you take it from a descriptive aspect. It shows you that wood sticks seem to have an effect on gingival inflammation, interdental brushes on plaque and pocket depth, and the oral irrigator seems to have an effect on gingival inflammation and pocket depth as well. But as I said, the descriptive analysis is not the highest level of evidence that we have. You can go one step above this, which is a meta-analysis. And only for 2 interdental tools we were able to perform a meta-analysis. And these were floss and the interdental brush. And from this you can tell with a very high level of evidence that if you have a perio patient, he should use an interdental brush in order to clean the interproximal aspect of his teeth. And this is the best summary of the best summary I could provide you with. But let's go back to the evidence-based decision. The evidence is out there with respect to interdental brushes. Maybe the patient enjoys it better. It is available in your country, but you have a strange clinical experience. The clinical experience could be that you have patients that misuse the interdental brush, as some try to remove tooth substance with it. Others try to destroy their interdental papilla, and some go even to bigger extremes and even perforating the interdental papilla. And this patient tried to, a few years from now there will be no more teeth left in his oral cavity. So please understand that I presented to you this morning the scientific evidence is out there, but it is also in your hands and the hands of the patients, which is the final effect that you get. While providing these lectures, I've had, many concerns from hygienists saying, I always use floss and it seems to work, and now you tell me that it doesn't work. And maybe it's what the philosopher said, every change will frighten a happy man. But for me, as a scientist, This change makes me very happy because it opens up new frontiers of research. So I'm not as much concerned as many professionals, and I'd like to open you up to thinking about it in an evidence-based way. If you're interested in what we published, we also published a paper not only on interdental oral hygiene products, but also on the systematic reviews with respect to mechanical plaque control. I'd like to invite you to have a look at this issue of the Periodontology 2000, where together with Dagmar I wrote a summary of all the systematic reviews that we've done so far. Well, I hope I haven't confused you too much with all the information, and although this slide tells you that it's the end, it's not the end, but it's the end of the evidence. So this is as much evidence that we have. But maybe you have the same experience. I have patients come into my office over the past 2 years that they say, now I'm using a product which is really good. I really enjoy using this. There's no evidence. There's 2 papers. One is not directly related to this product. The other one actually assesses this product, but that's all we have. So in order for you to advise your patient to use these soft picks, I think we need to wait for more evidence, more studies, because we don't know whether it has an effect for our patients yet. Okay, with this message, I'd like to finish off by showing you this last video fragment, the other Hollywood movie that has flossing in it. And just have a look.
Do you have an appointment?
No, but he's overdue.
Open. Now, see what the damage is, shall we? All these years, and you haven't flossed.
Not once.
Thank you for your attention.